We'll move on now to our last speaker. It is my pleasure to welcome Dr. Ahmad Saeed, who's a consultant and deputy chairman at Princess Noura Cancer Center and Ministry of National Guard, Western Region. He will talk to us about chronic lymphocytic leukemia, and the title of his talk is Delving Deep into CLL. Dr. Ahmad, welcome.
Assalamu alaikum, الصوت واضح?
Yes, we hear you loud and clear.
I'd like to thank organizing committee for inviting me for this lecture. So today, I know this is the last talk of the day, so people maybe get tired by now, and I hope it will be quick and soft. So today, slide is clear. Okay. So this is my disclaimer and disclosures. I will talk about some updates on CLL, and during this talk there will be a few interactive questions. So please scan your camera against the barcode and start to answer the question. So the first question is, what are your top 3 factors influencing treatment choice and first line setting? There are some more options. Okay, so we can move now. So I will start by giving some overview on the first line clinical updates. As everyone knows that during the last decade, the treatment of CLL has been revolutionized by introducing the novel agents. And by now we have some enough long period to assess the long-term or the longer effect of these novel agents. Starting by ibrutinib monotherapy, after testing, after encouraging results of ibrutinib in relapse setting, it was tested in the naive patients, and in the RESONATE-2 studies, ibrutinib was tested against chlorambucil in patients with previously untreated CLL, elderly patients, so 269 patients. Primary analysis and the current follow-up showed an impressive results. Now with the 7 years follow-up, as you see, ibrutinib compared to chlorambucil showed a significant difference in progression-free survival, with a median progression-free survival not reached in the ibrutinib group compared to the 15 months in the chlorambucil group with a significant hazard ratio. This results encourage people to test ibrutinib either as a monotherapy or in combination with the anti-CD20 monoclonal antibodies in a different scenarios of CLL. So it was tested for young fit patients and for older patients who are not fit for FCR but fit for BR, and also for elderly unfit patients. So FCR was considered the standard of care for young and fit CLL patients for a long time. And the ECOG 1912 trial tested ibrutinib against FCR in a young fit patients with a median age of 58 years, 529 fit patients with no deletion, 17p minus was included. And after 48 months median follow-up, there was significant difference in favor of ibrutinib and rituximab against FCR. So in this study, ibrutinib was combined with rituximab versus FCR. In alliance studies, ibrutinib was tested as a monotherapy or in addition to rituximab against bendamustine rituximab for elder patients who are age more than 65. And in this trial, 17B- was allowed to be included. And after median follow-up of 38 months, ibrutinib as a single agent or ibrutinib in addition to rituximab showed significant difference in compared to bendamustine rituximab in this group of patients. And finally, ibrutinib in Illuminate trial also in a combination with obinutuzumab was tested against chlorambucil obinutuzumab in elderly patients who were unfit for chemoimmunotherapy, and the median age was 71 years, and 70B- included. Again, ibrutinib, in addition to obinutuzumab, was significantly better than chlorambucil obinutuzumab in these patients. So there was clear evidence that ibrutinib against chemoimmunotherapy in a different group of CLL patients is showing effective and sustained response in CLL frontline. What about using other novel agents? So CLL-14 tested venetoclax in combination with obinutuzumab against chlorambucil obinutuzumab in elderly patients with comorbidities. What is special about this trial, CLL trial, that is it is with fixed duration treatment where patients received only 12 months duration of treatment. So with a median observation of 52 months, and all patients were off treatment for 3 years or more, the median progression-free survival in venetoclax obinutuzumab not reached against 36 months, 0.4 in obinutuzumab chlorambucil, and 74% of patients on the interventional arm were free of progression at 4 years of treatment, compared to only 35% of patients on control arm. Again, in CLL trial, time to next treatment was clearly in favor of venetoclax obinutuzumab, where the risk of starting new treatment was reduced by 54%, and the 3 years post-treatment therapy, 81% of patients in venetoclax obinutuzumab did not require any treatment. The last novel agents in the front line is acalabrutinib, which is a second-generation BTKI. So it was tested in Elevate treatment-naive patients as a single agent or as in combination with obinutuzumab against obinutuzumab chlorambucil in CLL patient aged more than 65 years, or if the younger patients with comorbidities. And again, it showed the same thing, the median progression-free survival for acalabrutinib alone or in combination not reached against 27 months or 28 months for patients on obinutuzumab chlorambucil. And at 4 years, the progression-free survival was 87 and 78 for acalabrutinib arms against only 25% of patients on obinutuzumab chlorambucil. So all these clinical trials showed clear efficacy of the novel agents and sustained the efficacy of these novel agents against different chemoimmunotherapy protocols. And next question, what about the safety profile of these novel agents? So ibrutinib has a well-characterized safety profile in all clinical trials used ibrutinib, and it showed much less myelosuppression compared to chemoimmunotherapy, but it showed some well-characterized and specific adverse events like atrial fibrillations, hypertension, bleeding, and maybe a slight increase of risk of infection compared to chemoimmunotherapy. But generally, it was well tolerated and fair toxicity profile. Regarding the venetoclax, the safety profile, brentuximab was consistent with the non-safety profile, venetoclax, and grade 3 and 4 toxicities in CLL14 were similar between the venetoclax arm and chemoimmunotherapy arm. Acalabrutinib also has a manageable toxicity profile, and one of interesting is that maybe the incidence of a specific adverse event seen in ibrutinib is maybe it's seen less with acalabrutinib being a more selective BTK, so we see less atrial fibrillation, less hypertension, and maybe less bleeding. So this is about it. Now moving to another important aspects, where historically it was known that the patients with deletion 17p minus or TP53 mutation has the worst prognosis in CLL. So what is the impact of using these novel agents on this high-risk subgroup of CLL patients? So starting again by questions, interactive questions. So again, please scan your camera again at the barcode and answer this question. Which therapy would you select for frontline CLL 17p TP53 mutated patients? Please start. Okay, so we move. So in all the clinical trials, some of them they did not include 17p minus like Resonate study, but other studies did include 17p minus. Also, the number of 17p minus were small numbers, but if you see in these trials, CLL14 Alliance or Elevate treatment-naive patients, it's clearly that the novel agents as single agents or in combination showed a significant benefit for deletion for 17 abnormalities compared to chemoimmunotherapy. In CLL14 in Alliance, the median progression-free survival not reached compared to 7 months for patients on BR, and in Elevate TN, the progression-free survival for 17p minus was not reached compared to 17 months for this. So there is a clear, although the number is small, but there is clear benefit of using novel agents for treatment of patients with 17 deletion and p53 mutation. Now, if you compare the outcome in 17p minus to non-17p minus patients, you see comparable results when use novel agents or near to. So in CLL14, in 17p minus, 4 years progression-free survival was 53 compared to 74 for non-17p minus patients. And for Alliance patients, when you use ibrutinib for 17p and non-17p, there is a comparable results as well as when you use acalabrutinib. So currently, what is the treatment of choice for patients of 17p minus as a front line, answering the interactive questions? So if we go by two major bodies, NCCN and ISMO guidelines, so both of them, they put novel agents as preferred regimens for all patients with TP53 mutation or deletion 17p. with ibrutinib, acalabrutinib, VIN-O or VIN or idelalisib plus rituximab. The evidence is 3A because of low number of patients included in trials. One most important point is mentioned by NCCN is that chemoimmunotherapy is not recommended since deletion 17p TP53 is associated with lower response rate. Moving to another subgroup in CLL patients, what is the impact of IGHV status on frontline in patients treated with novel agents in frontline? As we know, the patients with unmutated IGHV status, they have a poor outcome. So we will start again with the interactive question. Which therapy would you select for frontline CLL unmutated IGHV? So please. So majority is, okay, so we'll move. So again, when we go for subgroup analysis for frontline trials, comparing novel agents with chemoimmunotherapy in regards of IGHV unmutated, it's clearly again in favor of novel agents. In CLL 14, the median progression-free survival is 15.7 months compared to 26 months. And in Resonate 2, also median progression-free survival not reached compared to 9 months. And in Elevate in acalabrutinib trials, the median progression-free survival in acalabrutinib single agents or in combination with the obinutuzumab not reached compared to 22 months, and again also in Alliance trial. So there is a clear benefit of novel agents in regards of IGHV unmutated patients. What about testing it for in regards of mutated and unmutated? Generally, we see that both of them, they have a comparable outcome whether the patient has unmutated or mutated IGHV status. Now, this slides ISMO guidelines in 2021 regarding the frontline treatment for CLL patients. So the most important factors you decide on is the presence or absence of TP53 and deletion of 17p, the mutational status, and the fitness of the patients. Generally, in chemoimmunotherapy is not recommended except in exceptional cases, if there is a contraindication for novel agents or if it is not available, but otherwise you go for novel agents. Now moving to relapse refractory CLL clinical trial updates. So Murano trials is a trial tested for relapsed refractory CLL patients where patients were randomized between venetoclax rituximab against bendamustine rituximab, and the treatment duration was fixed for 24 months. And the initial results, primary analysis after 2 years, showed again significant difference between the two arms, with median progression-free survival not reached for the venetoclax arm compared to 17 months for bendamustine rituximab, and the 2 years progression-free survival was 85% compared to 36% for bendamustine rituximab. And after 5 years follow-up with longer follow-up, this effect is maintained with a sustained effect of venetoclax rituximab with a median progression-free survival of 53 months compared to 17 months and significant hazard ratio. What about patients with deletion 17p minus in this trial? Again, the same effect is maintained with a significant outcome favoring venetoclax rituximab compared to bendamustine rituximab. So the median progression-free survival the 2 years progression-free survival was 81% for these patients on venetoclax rituximab compared to bendamustine rituximab of about 28%. And we see that there is a comparable also results in regard with their patients they have deletion 17p or no deletion 17p. Another trial for relapse refractory is a RESONATE trials, and with which tested ibrutinib against ofatumumab, and the primary analysis after follow-up of 9 months showed significant progression-free survival in favor of ibrutinib, with the median progression-free survival not reached in ibrutinib arm compared to 8 months in ofatumumab. And after 65 months follow-up, this effect is sustained with a median progression-free survival in ibrutinib arm of 44 months, and at 60 months, the estimated progression-free survival was 40%, while in ofatumumab, the median progression survival was 8 months, and at 60 months, the estimated progression-free survival was only 3%. And if you remember, in Murano studies, with indirect comparison in Murano studies, the 5-year analysis, the median progression-free survival was 53 months for patients on venetoclax, and the estimated 5-year progression-free survival was 38%, with the patients is off treatment for 3 years. Another study is a SEND study, which compared acalabrutinib against idelalisib rituximab or bendamustine rituximab, and whether progression-free survival by IRC or investigator assist progression-free survival was clearly in favor of acalabrutinib, with the median progression-free survival not reached for acalabrutinib and around 16 months for control arm with a significant hazard ratio. And again, the 12 months progression-free survival in acalabrutinib was 88%. And if you remember, in Murano studies, after 2 years of treatment, the median progression-free survival was not reached, and the 2-year progression-free survival was 84%. And after 5 years, the median progression-free survival was 43.6 months with venetoclax versus 17 months with bendamustine rituximab. Regarding 17p minus in acalabrutinib study, again, it showed the same benefit like the previous results with acalabrutinib, either there is a deletion, 17p deletion or no 17p deletion, the results are comparable. Moving to another aspect, which is the MRD negativity in CLL patients, and this is very interesting point as mentioned earlier in the previous papers, because patients with MRD, with undetectable MRD, this could be a surrogate markers for better survival outcomes. So which therapy would you expect to see higher undetectable MRD results? acalabrutinib, obinutuzumab, venetoclax, obinutuzumab, or abratinib. Please vote. Okay, so for the sake of time, so venetoclax obinutuzumab, it showed that MRD reduction in peripheral blood was 76% in venetoclax obinutuzumab in comparison to 35% in obinutuzumab chlorambucil. And if we checked in the bone marrow, it was 57% compared to 17%. So a higher and significant higher number of patients achieved MRD negativity in CLL 14 frontline treatment. What about in the relapse setting? Again, with the venetoclax combination, the number of undetectable MRD was 62% in the peripheral blood compared to 13% for patients with bendamustine rituximab. And in the bone marrow, it was at the end of treatment was 16% compared to 1%. So venetoclax-based treatment really showed a significant number of undetectable MRD in these patients, both in the front line and in the relapse setting. While it's known that abratinib, either as a single agent or in combination, is associated with lower CR and very low rate of MRD negativity, as shown by most of the in all of the trials, where undetectable MRD was very low in abratinib group in all the clinical trials. Acalabrutinib also, as a single agent or in combination, was associated with also a lower rate of undetectable MRD negativity. So the best combination is the venetoclax based treatment in regards of having a higher rate of undetectable MRD. Another aspect or another very interesting point is the continuous versus fixed treatment therapy. Abratinib trials and the acalabrutinib trials is based on continuous treatment, while some trials of venetoclax-based treatment in frontline was 1 year, in CLL 14 was 12 months duration, and in Morano study was a 24 months duration. And this is having interesting to the regarding many aspects in regards of convenience for the patients, regarding the cost, and in addition also it has other important. But let's go by voting on this last question. So do you prefer fixed treatment duration over continuous therapy? Okay, so there is no one answering no. That's good. So one important thing is the development of mutation, and this is seen clearly in a continuous treatment with abratinib, whether in the front line or in the setting of relapse refractory. And again, also it is seen in more, especially in more in patients who is having deletion 17p or TP53, where presence of deletion 17p and TP53 increase the risk of PTK mutation, whether in the first line or second line. Another, while in venetoclax or PCL2 inhibitors venetoclax study, there was no acquired mutation in PCL2 family genes when venetoclax is used in combination with obinutuzumab. Regarding the common adverse events, as we see in ibrutinib trials, we continue to see the adverse events of clinical interest over time. And as you see, like hypertension, still you see it after 6 to 7 years. You do see you see the these adverse events, atrial fibrillations, and other. So continuous treatment is still associated with adverse events, and about 23% of patients, they have either dose reduction or discontinuation of ibrutinib because of toxicity. While in venetoclax-based treatment, last slide.
You are wrapping up.
Last slide. So in venetoclax study, we do see the adverse event mostly during the combination treatment, and it's getting less after combination. And post end of treatment, we rarely see any adverse events, and this is a clear advantage of fixed duration treatment. And with this, I come to the end of my talk. I'm sorry if I did take a longer time. And again, thank you, Dr. Ayman and Dr. Musab and the organizing committee.
Thank you very much, Dr. Ahmed. That was a very nice presentation, diving deep in CLL. It seems that we don't have questions posted by the audience. I do have too many questions in CLL, but maybe there is no time to answer all these questions. Maybe just one thing regarding chemoimmunotherapy, Ahmed. Let's look at the unmutated group of patients in the frontline setting. Is there still any role of chemoimmunotherapy, do you think, in that group, the unmutated, young and fit patients who are not 17p deleted?
Or regarding the guidelines, I would like to double check with you. You mean the unmutated or the mutated?
The unmutated group.
So the mutated,
frontline.
I think the mutated answer maybe is more clearly in favor of the novel agents. But there was a question about the mutated group where FCR in these patients, young fit patients with a mutated group, the 8 years progression-free survival was about 60% and CLL 8 with a possible cure in this patient. So the question comes for this group of patients, would you still use chemoimmunotherapy or you go for novel agents? And still, I think novel agents, especially if you go for fixed duration based novel agents, maybe this is the right choice for them.
All right, thank you, Dr. Ahmed. And I guess with this, we conclude the Satellite Symposium of AbbVie. Thank you very much. And we come to the end of the day today. And now, on behalf of Saudi Society of Blood and Marrow Transplant, I would like to sincerely thank all speakers throughout the day. And I appreciate really the presence of a huge number of the audience since 2 p.m. today. Is just a reminder for tomorrow, please. The program tomorrow will start at 2 p.m. for the hematopathology overview meeting tomorrow. So please be there. And thank you very much for everybody. And good night. Goodbye for now. Thank you.
Thank you, Ayman.